Good afternoon. My name is Greg Wahlstrom, and I would like to welcome you to the American College of Healthcare Executives Central Illinois chapter webinar entitled Sustaining a Financially Vibrant Healthcare Organization. ACHE has authorized 1.5 hours of qualified education credit for this presentation. In order to receive ACHE credit, each participant will need to log into his or her ACHE account and insert the webinar information to receive ACHE credit for today's webinar. After the webinar, you will be directed to a short survey, which the Education Committee hopes you will take the time to fill out. If any IT problems arise, please visit support.anymeaning.com for further assistance. As we begin the presentation, can you please mute your telephone lines until the question and answer portion of the event? On the left-hand side of the webinar platform screen, there is a text box to write a question to the presenters that will be answered at the end of the presentation. If you have a specific question to one of the presenters that you would ask, please insert the question into the text box. If you have a specific question for a specific presenter, please put their name next to your question in the text box. Just as a reminder, this webinar is being recorded. Today's program, today healthcare executives face many challenges and issues, such as workforce shortages to the need to update technology and make facility infrastructure improvements, as well as provide safe, high-quality patient care for financial challenges extraordinarily complex. In addition, healthcare leaders face ever-increasing regulatory demands and diminishing financial rewards. What organization strategies are available to healthcare executives to affect their organization's bottom line and supply chain costs and revenue? What are the critical links that exist between financial and non-financial managers, or clinical and non-clinical managers, that can impact the financial health of departments and the organization as a whole? Today's topics are: how can hospitals survive and thrive in the future? What are some of the best practices put in place by healthcare organizations that have effectively reduced expenses and still maintain high-quality patient care? What are some of the key financial principles that healthcare organizations should use as guidelines for their own operations? And what are some of the most pressing issues facing your healthcare organization today? What are the best ways to address financial problems internally? What strategies have your organization used to address a degenerating financial situation? And when is a consultant or an outside solution required? What methods must a healthcare executive use to begin to ensure future financial solvency? How can others on the top management team help identify solutions? Do you know of other healthcare organizations that have reversed inadequate revenue cycle management, such as low self-pay collections, insurance denials, incorrect or improper coding, etc., or demonstrated other financial turnarounds? How have they accomplished this? How can these be implemented into practice in your institution? And what role should your healthcare executive play in their own department to ensure the overall financial health of the organization? Today's moderator, Charles Stewart, FACHE, MS, MA, Market Chief Executive Officer, Sparks Health System. Charles Stewart is currently the Market CEO for the Sparks Health System in Fort Smith, Arkansas. Sparks includes a 492-bed Sparks Regional Medical Center and 103 Summit Medical Center, plus over 100 employed physicians. He has previously held CEO positions in Missouri, Alabama, and Mississippi in both for-profit and non-for-profit health systems. With 30 years of healthcare experience, Mr. Stewart is fellow in the ACHE. Mr. Stewart was awarded the ACHE Senior Executive Regents Award in Alabama in 2005. He has served on several Chamber of Commerce Board of Directors, presently on the Fort Smith, Arkansas Chamber Board. He was a former board member and chairman of the East Tennessee Northwest Georgia Better Business Bureau. In 2005, Mr. Stewart was featured in March-April issue of Healthcare Executive under the section of Healthcare Management Ethics Charles holds a bachelor's degree from Jacksonville State University with a major in psychology and a master's of science degree in counseling and guidance and hospital and health administration from the University of Alabama, Birmingham. Vicki Schroeder, healthcare executive, independent consultant. Vicki is a healthcare leader with over 25 years of progressive experience in the industry. She has held leadership roles in hospital and corporate environments, including surgery, finance, information systems, strategy execution, and transformation. Her experience includes CHE Trinity, Trinity Health, St. Joseph Mercy Health System, and Borges Medical Center. Vicki successfully led one of the largest transformational initiatives for Trinity Health called Project Genesis, to improve clinical and revenue operations through standardization of systems, processes, and culture. The success of this initiative improved performance and positioned Trinity Health for national recognition in areas of CPOE adoption, advocacy, bond agencies, and quality, including the Thomson Reuters Quality Award in 2009. Her leadership expanded to include several mission-critical strategies such as clinical integration network, preparation for population health management, merger and acquisition integration, and various operational improvement challenges. Vicki holds a master's degree in healthcare from Zayina Health University and a bachelor's from Nazareth College, achieving summa cum laude. She is a member of ACHE and also a peer reviewer for the Journal of Healthcare Management. She has been invited to present at various universities on topics such as merger and acquisition, healthcare leadership and transformation. And Vicki is a Michigan native and currently lives in Ann Arbor, Michigan, and her husband and high school daughter. David L. Callecod, FACHE, MBA, President and CEO, Lafayette General Health System. David L. Callecod became President and CEO of Lafayette General Medical Center in July 2008 and was elevated to the system's president in July 2013. He is a fellow of the American College of Healthcare Executives, FACHE. In October 2011, Callecod was introduced into Stewart Group's Firestarter Hall of Fame at the What's Right in Healthcare Conference for his ability to keep the true spirit of an organization alive and flourishing, while achieving phenomenal results in short spans of time under his leadership. Lafayette General has experienced rapid improvement in both patient satisfaction and quality measurement, all while expanding the hospital itself, its regional network, and its award-winning care. Inpatient satisfaction at LGMC continued a steady climb, reaching the 99th percentile in July 2011, starting a trend of scores continually in the 97th percentile or above. The hospital's journey to excellence was noted by Stewart Group as a recipient of the Excellence in Patient Care for Physicians, Most Improved Hospital Inpatient Satisfaction, as the Healthcare Organization of the Month in July 2011. Since 2009, HealthGrade's awards include a top 10% in the nation ranking for orthopedic surgery, prostatectomy, overall gastrointestinal services, and general surgery, and the HealthGrade Service Excellent Award for Patient Safety, in addition to numerous recognitions and 5-star ratings. Prior to joining Lafayette General, Callecod served as the president and CEO at Marion General Hospital in Marion, Indiana, from 2003 to 2008. While at MGH, the hospital saw record patient satisfaction and quality measures, as well as top 100 hospital awards in 2007 and 2008. Marion General also received several HealthGrade 5-star awards during his tenure and Magnet Hospital status in 2008. Callecod received the 2005 Regents Award and an Outstanding Healthcare Executive from the American College of Healthcare Executives. Callecod began his career in 1989 at AMI, Culver Union Hospital in Crawfordville, Indiana. He then served as CEO at Tenet Healthcare Hospitals in Indianapolis, Indiana, and Searcy, Arkansas from 1999 to 2003. In 2001, Callecod was recognized by the Indianapolis Business Journal as a 40 Under 40 award winner The same year, he was bestowed an Outstanding Achievement Award in the business from Indiana Wesleyan University. Callecod received his Bachelor's of Arts from Wabash College in 1989 and a Master's of Business Administration from Indiana Wesleyan University in 1994. He was honored and a distinguished alumnus by IWU in 2007, and Callecod is active on many boards, including the Louisiana Hospital Association, Blueprint Louisiana, Greater Lafayette Chamber of Commerce, and AHA Regional Policy Board. In addition, he serves in the Louisiana Economic Development Ambassador Program. Michael Connelly, CPA, MBA, President and Chief Executive Officer, Huggins Hospital. Mike has over 25 years of broad and varied experience in the healthcare industry. Over the course of his career, he has worked with integrated delivery systems, academic, medical centers, community hospitals, physician groups, community health centers, human service providers, and emergency medical service providers. In his role at Huggins Hospital, Mike is leading a cultural transformation as well as a search for a strategic affiliation partner. Prior to joining Huggins in 2012 as the Executive Vice President and Chief Operating Officer, Mike was President and CEO of Provider Logic Incorporated, a healthcare consulting firm located in the greater Boston area, and was the Partners Health Grade System, parent company of the Massachusetts General Hospital and the Birmingham and Women's Hospital in Boston from 1997 to 2000, and again from 2001 to 2007, where he held management positions in finance, hospital operations, and physician practice operations. His area of expertise includes executive and transformational leadership, strategic planning, finance, operations, governance, and community relations. Mike is particularly well known for his turnaround experience, his ability to build high-functioning teams, and to drive improved financial and operational performance for healthcare organizations. A certified public accountant, he received a Bachelor's of Science in Business Administration with a major in accounting from Salem State College in Salem, Massachusetts, and a Bachelor's of Business Administration with a concentration in Operations Management from Bentley College in Waltham, Massachusetts. From 2010 to 2011, he served as the President and Chairman of the Board of the Healthcare Financial Management Association, HFMA, Massachusetts, Rhode Island chapter, where he has been active since 1993. Additionally, Mike serves on the adjunct faculty at Simmons College and the Boston University School of Public Health, where he taught several courses on non-for-profit accounting and healthcare finance. He currently serves on the board of the New Hampshire Hospital Association, the Wolfboro Area Chamber of Commerce, and the Town of Wolfboro Economic Development Committee, and he serves on numerous non-for-profit boards and civic organizations over the course of his career. In addition to HFMA, Mike holds memberships in the American College of Healthcare Executives and the American Institute of Certified Public Accountants. A native of the greater Boston area, Mike currently resides in Turfboro, New Hampshire, and he is married with 3 college-age children. Now I'd like to pass the floor over to today's moderator, Charles Stewart. Good afternoon, Charles.
Good afternoon, Greg, and good afternoon, everyone on the line. I think we would all agree that we are in an era of the greatest amount of change our industry has ever experienced. It is a time when everyone, I think, in our field has many questions about how we can not only ensure that our organization is successful and survives, but I think we're all asking the questions, how can we sustain our mission of our organization as we move forward? And I think we've assembled a very distinguished group of speakers this afternoon, and hopefully through the conversation today we'll stimulate some ideas as to how we can better help you position your hospital for sustainability. So at this time I'll turn it back over to Greg.
Thank you, Charles. Now we're going to move on to our first speaker. I would like to introduce Vicki Schroeder. Good afternoon, Vicki.
Good afternoon. Thanks a lot. Welcome, everyone. And thank you, Greg, for putting this important topic together. And thanks, Charles, for the introduction as well. Um, as we think about how can a hospital survive and thrive in the future, I think it's pretty important to take a look at the healthcare landscape. It's changing pretty significantly, and it's changing pretty fast. So we are in the midst of change. It's going to continue for quite some time, probably forever. And as we look at that, there's some key points to that. We are moving into value-based type of environments, and for most organizations, that means keeping one foot in a fee-for-service and one foot in the value-based models. And doing that well certainly is going to be a challenge. As patient expectations change, patient satisfaction ratings are now public. There's the expectations from the payers and the providers. All of that is starting to change and cause quite a few of us some challenges. In the merger and acquisitions and everything in between, we are certainly seeing an increase in that activity. And in your own backyard with the Northwestern and Cadence recent activity. But that's showing about a 10% increase. 2013 showed about 10% increase from the last part of that year. Projections show 2014 being even stronger. And so that will not change. We'll see more of that. And a place where you all probably know all too well, we're seeing financial and operational challenges across the country. So volume trends are going down, especially on the acute care side. We're seeing higher deductibles, and both those higher deductibles are coming from employers and insurers, and that's leading to some bad debt. There's a big question on the table on what the physician employment model should look like and what's it going to cost. So I think that some organizations are rethinking that strategy or rethinking about that relationship. Probably the other piece that doesn't always get a lot of play is for nonprofits, bond ratings are usually a good access to capital. And so as financial challenges occur, sometimes the access to capital is a bit more challenging depending on where the bond rating stays. Something that has been questioned in our industry before for a lot of our nonprofits is a question of should we maintain nonprofit status. I think it was a few years ago in the state of Illinois that was actually on the House legislature, that there was a question about mandatory charitable contributions. And as more people become insured, that could raise up again. So, and I think the operational improvement challenges, while there's a lot of focus at time about operational improvement, it can be pretty difficult to sustain the gain. So, let's see if I can do this. There we go. Okay. So what do you do? And I take a look at and constructed this in a couple of ways, really to emphasize a couple key points. One is that for an organization to be to maintain and thrive in the future, they're going to need to be able to do two things exceptionally well. One is execute on strategy, and the other is going to be to execute on operational initiative and become even more efficient. And I have highlighted culture in its own box because it could have easily lived under the supporting infrastructure, but I didn't want to lose the importance of it. So as I constructed this and think about this, starting to look at strategies like clinically integrated networks and population health are going to evolve through time, and they're going to raise up in different parts of the country at different points in time. So starting to look at strategies on what your mission is, what your relationship to the community is, and how your vision, that will change. But I think being able to execute on both operational improvement and strategies are going to be part of that equation. There's some other pieces. I'm using population health. That's not the only thing that certainly an organization would invest in. Analytics, EMRs, if that hasn't been done, there's a lot of other kinds of things like, I'll highlight this later, but senior EDs and some other kinds of things that might make sense to your organization. The key point around strategies is, for a lot of organizations, a strategic plan is done and it lives sometimes on a desk. And so making it alive and well and integrating it with operational improvement is one way to really build momentum around it. And as you look at, although I highlighted manage within Medicare reimbursement, I think that's for anyone. I don't know anyone that's doing that. It's certainly maybe a benchmark to look at, but I think that taking a look at lean processes, integrating end-to-end process improvement, and I just highlighted a few areas. We've done that before. If we start to look at process improvement more with a mechanism to hardwire those improvements into the organization, we might be able to get a little more traction on sustaining the gain. I don't know about you, but it feels like we've looked at ED throughput a million different ways and a million different times, and I'm not sure if we've really nailed that one yet. So I think that's hardwiring might be a key to that. And the culture piece, it's important, and it's also a direction to try and develop an organization that's really a highly reliable organization that is responding to data-driven kinds of results. And that that's going to take some time to evolve. I do think that as we talk about surviving and thriving in the future, that's going to be a key piece to this. So when I put this construct together, really the supporting infrastructure is to develop an integrated plan. And the pieces underneath that are program management, change management, process improvement are all part of that. But it's really developing, taking your initiatives and forming a way to build momentum around that. Well, the interesting thing about interesting and challenging are that when you're in the midst of financial challenges, you can sometimes create an urgency for the organization and actually create a platform for change. And it does sometimes also give an organization the grace or the wherewithal to actually make some pretty tough decisions on what types of services you stay in, what types of partnerships you stay in, all those kinds of things that in normal kinds of environment you may not make those kinds of decisions. I think that as you look at creating a plan, you are starting to look at integrated plans that actually set targets around your initiatives and give you a way to measure your progress along the way. And when I usually look at these kinds of plans, it's with something that's, you're checking in on a 2-month basis, on a 4-month basis, those types of things. Not that people aren't looking at the results pretty routinely, but that there's a focused check-in on progress. And really the reason you're doing that is to identify where your barriers are and how to remove the barriers and how to kind of keep moving the organization in the right direction. And that gets at, it starts with leadership, and leadership does need to be totally engaged in this kind of work. Um, to answer some of the questions about what strategies have your organizations done to actually address this problem, just to give a backdrop, Trinity Health, when I worked there, has a variety of organizations across the country and a variety of sizes and shapes. So anything from an academic medical center to a 100-bed hospital and critical access hospitals. So some of these came up out of that work that I did with them. The first three boxes on the left, so the financial challenges and the program management and the clinical quality and financial targets, those were what I would consider blocking and tackling in how you start to address a financial or quality issue that you're trying to deal with. Within the Trinity organization, those types of things, there would always be targets, both on the quality side and the financial side, and there were plans underneath that that actually moved the organization to where you wanted to be in the next several months or the next year. If targets were not met, then the frequency of the discussion with the corporate team was actually pretty intense, and could be as much as every other week for several hours a day. On the less, if you were performing as planned, then maybe not so much. I mean, it was maybe a quarterly check-in or every other month. I have seen under extreme financial pressure, revenue cycle overhauls where really you take a look at if you're really achieving best practice around the revenue cycle and do an end-to-end overhaul. As well as we've probably all lived with and seen enough of the reduction in workforce that does tend to occur as the financial pressures hit and we're adjusting to volume trends. To get to my earlier point on being able to invest in strategies, what I also experienced was investment in analytics to really support evidence-based decision making, as well as analytics that really become kind of data-driven organizations and support the culture of becoming a highly reliable organization, as well as the senior EDs. I mean, if you're in a community that has an increasing population of seniors, it's certainly how you relate that to your community might show up in senior EDs or some other investments in care in the home and some other kinds of activities. And the last things really are standardization and centralization that occurs depending on, supply chain is certainly an area that usually you can gain some momentum around and how you standardize some products. And I'll touch on that on some of the partnership, but when you're starting to partner or think about a merger or a different kind of relationship with another organization, sometimes the standardization, centralization can really pay off. The other pieces that I've seen in communities are really reducing some of the duplicative services that are high cost and maybe not of value. And so helicopter programs sometimes have consolidated, or pediatrics, or even labor and delivery, as well as seeing some process improvement. One of the questions that was asked on the start was, when is a consultant or outside solution required? And there's a few considerations to that. This is not the all-inclusive list, but it's probably within the top 10. If your organization has a tremendous opportunity, either on the strategy side or on the reduction in financial risk, and you're really looking at accelerating whatever the implementation is, because the payoff is so great, so the benefit and the payoff is high, and you're trying to reduce risk. That's probably a time to bring in some outside help. The other pieces are you may have internal talent or not, and I think that needs to be considered, as well as um, even if you have internal talent, do you have the bandwidth? Are you able to free up people that you can get your initiatives done when you need to get them done? And the last two are really the objectivity. If it's more, if you are going to gain more by having an objective facilitator to work with physician groups or other health systems or organizations, then it might make sense to bring in some outside help, as well as you may want an outsider to take a look at your strategies, your organization leadership, and take a look at where your strengths are and where your weaknesses are and where your opportunities are.
Thank you, Vicki. Well, you already mentioned there about the perhaps when it's time to consider bringing in someone to help you determine if it's time to consider a merger. Another question, as our national health system moves toward clinical integration and population management, since most hospitals do still have a significant portion of their medical staff who are independent and not employed, what advice do you have to effectively bring these physicians on board in this changing delivery framework?
Well, there are a few components of that I think organizations need to focus on, and one of the biggest is really assessing your current relationship with your physicians and taking a look at where you are now and where you are today. And what that starts to allow is to create a framework on how you want to partner with physicians in the future and what that needs to look like. Now that can lead to developing and establishing physician leaders in a formal way, that you have governance and that you actually have a leader role. I think for those of you that are reading maybe Becker's, there was recently an article about a chief population health officer, and that gets at trying to bring somebody, a physician, into a leadership role that is formal. That whole positioning actually allows for docs to come to the table, because what you really want is you want those independents as well as the employed to really have a place at the table and to really figure this out. Nobody has all the answers. Nobody knows what exactly this needs to look like, and it may be different depending on your community. So being able to open that dialogue actually starts to bring that up. And I think one other piece that I'd add to that is, as a health organization, figuring out if you want to be the facilitator or to allow this to happen around you, and kind of jump in as a member later on. Figuring that out is probably a difficult task, but I would argue that I think most health systems want to be on the front end of that in the facilitating.
And one other question, Vicki, as we've seen, the trend today in our industry is in consolidation, where the numbers of hospitals are not part of the system are becoming fewer and fewer. For those hospitals that still remain independent, do you have any suggestions as to how they can achieve the same benefits that systems gain from standardization and centralization of various functions?
Yeah, I have a couple of thoughts about that, and it does relate a little bit to the merger and acquisition, but I frame it as merger, acquisition, and partner. I think that for independent organizations, there may be opportunities to develop relationships with others without going as formal as a merger and acquisition. And some areas that might make sense to look at are in the areas of analytics where you have an EMR and you really want to take clinical quality to the next level and you need some analytical support. So it might open the door in that kind of regard, as well as supply chain and revenue cycle. Having a partner with a little bit of formality around that, you might be able to jump onto supply chain contracts or some other kinds of things that an organization does well, and yet so leverage that opportunity, as well as I know some organizations have actually outsourced or taken on revenue cycles. So if you're doing those kinds of functions exceptionally well as an independent, you might want to consider a little bit of a business opportunity in that space as well.
Thank you, Vicki.
Thank you.
Hello, everyone. Sorry.
How's it going? Our next presenter is David Callecod with the Lafayette General Health System. So, David, if you will.
Sorry to jump in there, Charles. Thanks, everyone, for allowing me to be here today. I appreciate inviting someone from South Louisiana to participate. It's only 72 and sunny today here, and I apologize, but I did grow up in the Midwest, so I do know what all you've been going through this year. A little bit about our system before I start. We're a 5-hospital system, and we're in the process of acquiring at least 2 additional facilities this year. And so, one of the things that certainly I believe, and as you look at this slide, Vicki mentioned it, but it's all about culture. And when we talk about culture here, it really is how do we develop a culture that supports providing high value at low cost across the system, and having each of the facilities develop their own culture within the facility that supports that. Imagine where we are going, and we're going to a point where hospitals and hospital systems need to function much more like Sam's Club or perhaps Costco versus function as a mom-and-pop store that maybe is downtown. And so what we're trying to do across the system, whether it's a critical access hospital or our large 350-bed tertiary trauma facility, is how do we continually focus on providing high value at the lowest cost that we possibly can. One of the ways in which we focus on that is we firmly believe in having accountability at all levels of the organization. And accountability can only be obtained if you have objective measurement that is absolutely data-driven for every single department, and develop strategies to be focused on high reliability in every single area. We also believe in transparency across the organization. And so one of the things that we do in our journey to excellence is that we publish all of our data everywhere we possibly can. It is on our pillar boards throughout the organization. It is on our website. And we share everything with everyone. And we believe that the light that is shined onto those areas where we're not doing well is what really focuses on us to improve and really try to focus on being top decile in everything that we do. So accountability starts with certainly data, and data is used in our organization through our leader evaluation system. It makes no sense to hire consultants or go through a process of change and expense reduction in your facility if you do not have a coordinated leadership evaluation system for all leaders in the organization. And so we have a web-based tool that has every single leader has only objective goals. There are no subjective goals whatsoever. All that are driven by data for their individual departments. This leader evaluation system, as the CEO of the president of the system, and then each of our individual CEOs, has access to every one of the leadership results for their span of control within the organization at all times. This leader evaluation system is also used in the monthly model that we have, the monthly meetings that we have with leaders. But one of the important aspects that really echoes what Vicki shared is having those goals, having it data-driven with the leader evaluation system. Each leader has a 90-day plan for which they need to submit to their leader and be approved on this tool for every quarter of the year. And there's a process that we go through to approve that so that we never lose focus of what those goals are and what the focus of that leader needs to be in order to achieve each and every one of the objectives that they have. Now, the next item on there is the green box, which is the monthly meeting model. And it may sound sort of nebulous, but what we found in our organization is that every leader in our organization was conducting their monthly meetings in a different manner. They were focusing on items that really shouldn't have been front of mind. They were focusing on items that really weren't going to have a direct result in meeting those objective outcomes. And so we switched to a unified, standardized monthly meeting model for every leader of the organization. And it is a step-by-step process that each leader goes through in order to get 90-day plan results, get wins from the organization, from the departments, each individual department leader, and then be able to use that monthly meeting model as it then feeds their one-up. So imagine if you have the ICU director is using a standardized monthly meeting model that then is the framework for their meeting with the chief nurse, and the chief nurse then uses that exact same monthly meeting model, funneling in all of her direct reports for her meeting with the COO or the CEO of the facility. And so I really can't stress enough what the monthly meeting model has done for our organization to really get us to a different level of performance. And then the final item on this slide has to do with the Employee Idea Program. Every hospital needs to have one of these, and I've seen a lot of these where they actually fail because it really goes back to my first point. It's all about culture. We're a much better organization when we have 4,000 people committed to our success versus the C-suite being responsible for these every improvement that occurs in the organization. And so really having a vibrant employee idea program that rewards employees and also feeds into the monthly meeting model and the wins, which then lead to the feedback that is received at the highest level, the senior level of the organization. As we look at what are some of the key financial principles that we should use as guidelines throughout all hospitals, I'm a firm believer that if you're not focused on being top decile, the world has passed you by. And when we think about that, if you're in the top quartile with value-based purchasing, you're actually doing okay. But the issue is that if you're not getting better faster than the guy next door, you're going to quickly find yourself in a situation where you're not meeting the metrics, certainly, that CMS has put together. But even more importantly, as major insurers throughout every single market begin to adopt their own value-based purchasing model, the the bar is continually getting raised for each and every one of us. So for our leaders and for our individual CEOs, it is their responsibility to know who the top decile performer is in their like facility or their department that is in a like facility throughout the country. We do this through many avenues. Certainly, I would recommend using the folks from your own state within your state hospital association, as I know many states provide this data. Also, within a system, certainly one of the things we found is that we have top decile performers, even in our own backyard, in our own system, that we have not set up a mechanism for like leaders to interface with them and to get their best practices in order to improve performance in their departments. Another mechanism that folks can use to figure out top decile is through participation in either using Premier data or VHA data that many of your hospitals are members or of one of those organizations. And so really would encourage really everyone, particularly young leaders who are on this call, know who the top decile people are in your particular field of interest, and begin the process of figuring out how to get there. And we're going to talk about value-based purchasing on my final slide, but I just can't stress enough that if you're not getting better faster than other people, you're beginning the death process and you don't even know it. And so top decile is extremely important. We all are faced as well with this issue of doing more with less. We're not going to get paid more for services than we are today. We're seeing that in all of our negotiations that we're conducting. And so, as the reimbursement for all services begins to dwindle away to where Medicare perhaps becomes your best payer, we have got to figure out a way to do more with less. And so we're very focused on reducing our cost per unit, no matter what department that is, our cost per unit by 20%. We know that we're going to have to achieve this over the next 3 years, and so we're doing it in a number of ways. One, looking at how do we become more efficient in areas, looking at certainly a focus has been acquisition cost of everything that we have in the organization, really taking the work that perhaps just your materials management department has done related to negotiating prices on items such as implants, et cetera, but really taking that to a new level where we begin to do things like involving our physicians that we have brought on board, managing our service lines. And in our organization, we have service line management agreements in cardiology, neurosurgery, intensive care through our intensivists, hospitalists for our inpatient service, including nocturnist services. We also have surgicalists, which are general surgeons that are available 24/7 for that service. All of these, and I actually left one out, we actually have cardiology hospitalists as well. Every single one of these service line management agreements involve not only patient satisfaction and quality improvement in their agreements, but also the ability for us to really standardize processes. And so to really get to the point where you're using one type of hip, one vendor for that hip, one vendor for your neurosurgery implants. And, it's a tough thing to do, but for those items that we have always allowed there to be physician choice, to squeeze 20% of the cost out, we have got to have standardization at your hospital and also across your entire system. by far, I believe the most pressing. Yes. By far, one of the most. Yeah, by far one of the most pressing financial issues facing healthcare organizations going forward, I believe, is this issue of value-based purchasing. I had an opportunity to talk with Marilyn Tavener from CMS just a few weeks ago. She was here presenting at the Louisiana Hospital Association meeting. Value-based purchasing is a game where it truly is Darwinian. The folks that are in the bottom quartile right now for value-based purchasing, many of them, no matter what they do, are never going to get out of that bottom quartile. And so as the percentage of payment reduction continues to grow to where it exceeds 13% at full-on implementation, there are going to be hospitals across the country close very rapidly. And so I had an opportunity to pose this question to Marilyn Tavener, and the interesting response was that CMS knows very well that it's going to cause hospitals to close. And she didn't mention the number, but the rough number for everyone to know is that about 25% of the hospitals in the country probably will close before CMS changes value-based purchasing from a penalty program to an incentive program. And so I can't stress enough that if you're in the 50th percentile or hopefully you're not in the bottom quartile, every effort has to be made to get out of that bottom quartile, or your facility is absolutely not going to survive because of the draconian cuts. And so when you're looking at value-based purchasing and that effect, one of the things we all have to be careful of is we've got to be very cognizant of what it is we cut and why we cut it as it relates to expenses, because at the end of the day, there is more to be lost by falling in the VBP level than there is perhaps in the cutting of $200,000 or $300,000 of labor expense in a particular area if it's going to cause you to miss process of care measures. So got to be very careful moving forward. The final topic I had Vicki really addressed, and that's the issue that access to capital is going to become very, very tough going forward. The rating agencies are continuing to get more and more conservative and definitely moving toward an increasingly negative position about health care. And so it's going to be a challenge for all of us to access that capital need for future growth opportunities.
David, a couple of questions. You mentioned that one of your best practices for reducing expenses is accountability at all levels. What are some of the effective methods that you have put in place to bring that necessary accountability to all levels, and with what frequency do you monitor that?
Well, a couple examples. One, the transparency is a great example. All leaders are expected to have the results posted in the department at all times for their staff and also for anyone who's there. And so those results are monitored certainly on a monthly basis with their meetings, with their one-ups. But one of the best practices that we have developed at Lafayette General is that we have leadership development institutes every quarter where we bring all the leaders from all 5 hospitals together in one room. We have about 350 people there. And we have the ultimate in accountability, and that is we do the support service survey. So these are all the departments that support nursing and the delivery of care. Housekeeping, food service, materials management, central supply, et cetera, et cetera. And we conduct a 6-question polling device survey in front of God and everybody on the performance of those departments at that meeting. And so it is the ultimate in accountability. And for our leaders, we call it being comfortable being uncomfortable. But really, since that time where we have moved to that model, and this involves, does the leader round on the department? How quickly do you get supplies? How quickly is your nourishment station always fully stocked, et cetera, et cetera? since we have moved to that level of accountability, we have not moved from the 97th to the 99th percentile in inpatient satisfaction at 3 of our facilities.
That's excellent, and those are great ideas. One other question. To achieve the significant goal of reducing cost per unit by 20%, with the exception of a reduction in force, where have you seen the greatest opportunity to drive cost out of your system?
Well, first thing, I see a question on the chat, and the questions that we ask at the LDI are actually about the support departments and not the nursing department. So there are questions asked of everyone regarding support department work. In regard to the issue of the 20% reduction, which I think is what we talked about, Charles.
Yeah.
We've been very fortunate here. Certainly we're using best practices that we've learned from other people, and that's probably the main thing. But unlike a lot of areas across the country, we've been very fortunate that our unemployment rate is 3% or lower. We've had tremendous population growth, and so we've driven down the cost per unit because we've had, in many areas, just significant growth in volume. The main hospital itself has grown 14.8% this fiscal year over last fiscal year. And so what we're trying to do is be able to grow volume and keep costs flat, even with that. And so what we're doing is we're pushing people to even better performance on FTEs per EPD or FTEs per occupied bed, supply costs per day. We're doing everything we can to hold constant on overhead and on those operational costs as we've had the opportunity to grow volume in those areas, and just not adding people and trying to keep a lid on that.
Very good. I know there's another question on the from someone listening in. It says the importance of accountability, leadership evaluation, and standardized meetings resonate. Are there ways you have effectively used metrics to prove the benefit here?
Well, I think the one thing I've seen certainly as I've worked in various different organizations, whether it's for-profit or not-for-profit, one of the things I brought from my for-profit experience was that we try to have and share the same metrics at every meeting. So the board sees the same thing that the medical staff sees the same thing that department directors see, the leaders see, et cetera. And so that level of accountability at all levels, where everyone sees, warts and all, I think has been what has driven us to the dramatic improvement in performance that we've had. So, making sure the metrics are seen by every single level of the organization, I think, is very important.
Okay, thank you, David. Next, we'll move to Michael Connelly.
Good afternoon, folks. Thanks, Greg, Charles, Vicki, and David. It's been great so far. Happy to participate today. I guess the first thing that I'm going to talk about is this idea of future financial solvency, and I think we touched on a lot of the concepts and key ideas. But the things I wanted to go through were assessing and understanding the landscape. So I can't stress enough, as you think about your organization and future financial solvency, that you understand what's going on, of course, nationally with the ACA and so on, but also what's going on in your particular state. And I'm assuming that many of you are involved with your state hospital associations and so on, and that, at least for me here in New Hampshire, is a very good benefit in terms of really keeping tabs on bills being proposed, legislation and so on that impact hospitals. Then there's also regional and local issues and concerns. So I think it's just really important to make sure that you've got a good handle on that. I think as you think about future financial solvency, understanding at a real detail level your own organization situation, of course the finances, and having a really good, timely financial review process at all levels of the organization, not just at the C-suite and with the board, but with your department heads and managers and others. I think you need to understand your structural versus operational challenges. A little bit about my hospital here in New Hampshire. It's a critical access hospital. We're about $60 million in revenue. We have about 350 full-time equivalents, and we have a number of structural issues, quite frankly. Being a small critical access hospital, wanting to have 24/7 services in many areas. The reality is we probably have more than we need in terms of capacity, but we need that in order to maintain a 24/7 service. So you get into these sort of minimum staffing issues, and I really see that as a structural problem for our organization versus an operational challenge that could perhaps be improved. So understanding the difference between your structural and operational issues and opportunities. I also think that you need to realize at some level that you can't be everything to everybody, and you need to circle back to the mission and the vision and the values, and make sure that you're aligned there. Of course, comparing results to bench performance wherever possible. There's a lot of benchmark information available out there. You want to be comparing yourself to the best in class. You want to understand what the drivers of performance are, cost drivers and otherwise. And as I think many folks on today's call have mentioned, it's very, very important. It's critical to manage with data. When I came to this organization 3 years ago, quite frankly, they were not managing with data. There were no management reports and so on. So it's critical. You can't do the job without managing with data. We're going to get into this a little bit more later in terms of affiliation, I believe, but exploring options to collaborate and/or affiliate. I think particularly for small hospitals, although I know a lot of hospitals, I would say pretty much every hospital in New Hampshire here that I'm familiar with is at some level of discussion relative to collaboration or affiliation. And as Vicki mentioned, that can really range. There's a wide range there from sort of loose collaboration to merger to integration, full acquisition, and so on. But I think you need to look at that when you're thinking about finances. Every manager contributes to operational goal setting and monitoring. So you really need to move it down throughout the organization. It's not just at the senior level. People need to be educated. They need to be given the tools and the training needed. One of the things I saw when I came here to Huggins was that there wasn't a good dissemination of data throughout the organization. And you can't hold people accountable. You can't have a system of accountability if you're not sharing data and you're not sharing information throughout all levels of the organization. So it's really important that that gets moved down. People get educated and trained on the important things that need to be looking at and systems that they need to be accessing for information on a regular basis. It's really, really important, and I'm sure this makes common sense to people, that you have regular management team meetings. It's important that you have staff meetings at the department level. It's important that you have management team meetings, and of course it's important that you have senior team meetings. Information needs to filter down to the line staff, and very often the way that happens most effectively is through the department managers and directors. If they're not relaying that information that's coming from the senior team, then it's not surprising when you have a lot of staff in the organization that have no idea what's going on. So you got to make sure that that information gets filtered through. I can't stress this one enough. You really have to be aggressive about cost management. One of the things that we've been fortunately very successful here, despite our small size and somewhat structural challenges, is we've been able to pull a significant operating costs out of our system, about $3.8 million over the last 2.5 years, and for a $60 million organization, that's no small challenge. And the truth of the matter is we need to do even more, and we know that. It just starts to get a little bit scary when you kind of get down to those minimum staffing levels. Really what you begin to talk about is services. Interdepartmental communications through joint projects is a great way for others to get to know what their counterparts in other departments and so on are doing. One of the things that we did here at Huggins is we instituted a process of monthly management meetings where we would have a different department each month come through and present what was going on in their department. So they'd present some facts and figures about their department, how many FTEs, what type of work they do, how many visits they do, and so on. Maybe some quality initiatives or some service excellence initiatives that may be going through. This way folks got a chance to see what others in the organization were doing, maybe give them some ideas for some improvement efforts in their own departments. That's been very helpful. There have been specific initiatives that departments have gotten together on. For example, most recently our information technology group and revenue cycle folks have gotten together to kind of do a better job mapping out the front end process, the patient access processes regarding registration, admissions, pre-certifications, and so on. And that's been a very interesting and revealing process for all involved. In terms of revenue cycle management, I think this probably makes most sense to people. That revenue cycle really has to be a top focus. When I came here to Huggins, again, 2.5 years ago, we had some of the worst revenue cycle performance metrics in the state here in New Hampshire. I think our gross days in accounts receivable was somewhere around 70. Cash flow was struggling. We had a lot of claims that were held up in the system due to various edits that staff didn't know how to work and clear. So it has to be a top focus. It's got to be a top focus from the board. It's got to be a top focus at the senior management level, and it's got to be a top focus among all staff. And I'm sure folks have heard this, that it's not just a billing department issue. We spent quite a bit of time initially just educating the sort of general hospital population about the fact that revenue cycle is an organization-wide issue. It really starts at the time that a patient decides to receive services at your facility, when they call to schedule an appointment or they come into the emergency department. That's when the revenue cycle process really starts. And it doesn't end until they've received their final statement for their self-pay balance, and that's been cleared and so on. So there are a lot of steps in between, and that's why it's a organization-wide focus. Focusing on the fundamentals, I can't stress enough. Looking at workflows, routines, system functionality. We happen to be using multiple systems. We have one billing system for our hospital side, another billing system for the physicians. Providing adequate levels of training, access to resources, follow-up and feedback mechanisms for staff. A big piece of the improvement process for us on the revenue cycle, and I will sort of end by telling you, how successful we've been on this, was the charge master review, and really getting a sense of what's in your charge master, and probably bringing in some outside help with that, which we did. And clean up, and working with the folks in materials management to make sure you're capturing all your supply charges and things are priced appropriately. So there's a lot of work that's done interactively with the clinical departments to clean up the charge master. Policies and procedures, of course. You need policies and procedures because when you have staff turnover and you need to train people, people need to understand the way we do business. And if you don't have policies and procedures, that can be difficult. Front-end focus, of course. If you can't get it done right on the front end, the likelihood of getting paid on the back end decreases dramatically. So we initially had to do a lot of focusing on the back end because we couldn't get claims out the door. But since we've been successful with that, we now can shift our focus to the front end and looking at point-of-service collections as well, which we've been quite successful with over the last couple of years. As I mentioned earlier, engaging staff throughout the organization in the revenue cycle, continuing to reinforce that. Looking at benchmarks and setting goals. It's really important. We have cash targets, we have revenue targets, we have volume targets, and so on, and everybody knows what those are. And then last but not least, reporting and follow-up. You have to make sure that you have very good and robust reporting systems and follow-up mechanisms to be able to get back to the staff and let them know where we're doing well, where we're not doing so well. We're beginning the process of trying to develop a robust denial management system here at Huggins, and that's a lot of work, but I believe that will pay off for us in the end. I'm happy to say that over the 2.5 years that I've been here, we have been able to reduce the gross days in accounts receivable from 70 down to 48. We've improved our same-store cash collections by about $2 million a year. We have seen a 15% decrease in bad debt write-offs, and the customer complaints relative to billing are almost non-existent now compared to when I started. So, there's a lot involved with it, but those are some of the highlights in terms of reversing inadequate revenue cycle management. I'll have to say, prior to coming to Huggins, I was a consultant for a number of years, and we'd travel around across the country, and my specialty was really working on distressed situations where hospitals, were in trouble either with their bond covenants or they're having revenue cycle issues or leadership issues. And I think almost, consistently across every organization that I visited, there were revenue cycle problems. So it is an area where you can typically make a pretty big impact fairly quickly. The last one is a healthcare executive role to ensure financial health of the organization. I think most of these things hopefully make sense to people. Knowing your book of business, again, understanding the industry trends, your position in the market, do a market analysis, do a zip code analysis, of your business to see, where your patients are coming from, how much penetration you have in the particular service area that you serve, who are your competitors, what kinds of work do they do, how much business is getting sent to your competitors. There's ways to get that information. Of course, understanding your volumes, reimbursement methodologies. Typically we're paid fee for service. Are we going to be moving towards some type of, capitated payment in the future? I think quite possibly, but at this point in time for us, it's fee for service. Understanding your revenue, both gross and net. We've done a lot of education of department directors in particular in this organization where, is in a lot of hospitals that I've seen over the years, the focus is really on FTEs and expenses, but there really was very little understanding of how revenue works and are we ultimately collecting on the bills that are getting sent out the door. And I think that's been quite revealing and has actually helped to motivate a lot of positive change as department heads, whether it be in the lab or medical imaging or in surgery and so on, begin to see the results of are we actually collecting on the work that's being done. Staffing, of course, we've done a lot of work here relative to understanding staffing, looking to match staffing with volume based on benchmark wherever appropriate. We have aggressively managed overtime expense. When I came a couple of years ago, we were spending over $1 million a year in overtime. I'm happy to say that it's less than a third of that now. And a lot of that was just by publishing it. What gets managed, what gets measured gets managed. I'm sure you've heard that. So we look at it every pay cycle. We get paid every 2 weeks. We have a report that comes out on full-time equivalents by department versus budget, as well as overtime utilization, and I think that has really helped us tremendously. Understanding your cost structure, of course, at the department level, and whatever regulatory requirements there may be. Focusing on quality and customer service, and the financial results will follow. I was just doing a new employee orientation today at noontime here, and I said to the folks, I said, what we're really all about here is quality and customer service, and I believe if we do a good job with that, the finances will follow. The finances are kind of the lagging indicator. and communicating regularly with your staff on key business issues and opportunities. Talking with them, rounding and talking with them about the issues in their particular departments, talking about more organization-wide issues, regularly reviewing key performance indicators at all levels. I mentioned that earlier. Developing performance targets, whether it be through the budget or through some interim improvement process. Undertaking initiatives that add value and reject those that don't add value. So, doing return on investment analysis, looking at how it's going to impact quality of care and patient satisfaction, those kinds of things. So it is heavily about the finances, of course, but there were it's not always a complete finance focus. Don't accept the status quo. Boy, is that hard. When you're coming in as a change agent. I mean, that's your mantra is, it's transformation, and that's my job, is to be sort of the transformational leader. And so you really have to question the assumptions, and you have to question the status quo and whether or not it's really working for the organization. And again, don't be afraid to challenge those assumptions that don't make sense or don't seem to be adding value to the patient experience. Lastly, be transparent. Don't be afraid to over-communicate. Make sure you're communicating regularly, openly, and honestly with all of your constituents. One of the things that we instituted back in the fall of 2012 was what we call a quarterly town meeting or town hall meeting. It's basically multiple sessions once a quarter where myself and other senior leaders of the organization are available to give updates and answer questions for all staff across the organization. And we've seen great attendance with that, and I've gotten really good feedback about that process. And be a champion for change. As Vicki mentioned, we're going through an unprecedented time of change, and I don't think there's any running from it. You got to face it and deal with it, and it's all good stuff. So thanks.
Michael, a few questions. With the intense focus hospitals are experienced with the RAC audits, monitoring the patients and observation status, lengths of stay, all those things that we're all having to work on, what processes has your organization put into place to ensure that, one, patients are receiving the care in the most appropriate setting, but also in the most cost-effective setting to safeguard the hospital from outside scrutiny?
It's a good question. Well, we use the interqual criteria to look at determining appropriate level of care and length of stay. Our utilization management department participates in an interdisciplinary meeting held each morning where patient treatment plans and discharge plans are reviewed with attention to length of stay and level of care. We frequently consult with our physicians on an individual basis regarding the specific patients and level of care and length of stay issues and concerns, and offer supportive advice related to the mandated practitioner documentation that's required to support that level of care and length of stay. We also provide education and support for nursing supervisors who review new and potential admissions for appropriate level of care. Our utilization management committee meets on a monthly basis to review stats and statistical data relative to length of stay and level of care, as well as we do regular medical record reviews of patients with extended stays or level of care questions and issues. So I think we've got a pretty robust process that has been pretty successful for us. And I think like everybody, we face questions about observation status versus acute status. We have a new intermediary serving this area. We have definitely seen a huge uptick in the number of prospective as well as retrospective reviews asking for more information. So we're kind of on alert and making sure that we're working within the appropriate processes there.
Yeah, I think it's an issue everybody's dealing with. You also mentioned how important front-end point-of-service collections have become essential in the improving revenue cycle. I'm sure we're all seeing the number of patients that are experiencing significant amounts in their copays and deductibles. A couple of questions. How has your organization dealt with the patient who simply says, I don't have the funds needed to meet that high amount of money that they have to pay on the front end? And then how do you effectively deal with the referring physician when this recurs?
Excellent questions. Well, we've certainly recognized this as a growing issue, and we are in the process actually of kind of finalizing some policies and procedures around this. But some of the things that we have begun to do is, for example, for scheduled surgeries, the admitting registration person forwards the patient information to the financial counselors that we have on staff, who contacts the patients to discuss a deposit. So we've begun a process of, again, for those elective surgeries that are scheduled in advance, trying to secure a deposit from folks. For those folks that are unable to pay, we pursue whatever avenues of available financial assistance are available. We would consider a budget plan, after discussion with the patient, maybe even consultation with the provider's office. We also offer prompt pay discounts, and that often enables the patient to be able to pay. The financial counselors themselves are able to offer up to a certain percentage of that financial discount. Anything above that percentage, it has to be approved by the Director of Revenue Cycle. Our philosophy is for surgeries that the patient will have a bill that's likely significantly larger than the deductible, so we try to get whatever we can up front, realizing post-surgery we'll only get the insurance payment. We also do a lot of infusions here, and what we do with the infusions, since they can be high-dollar drug situations, we verify insurance and medical necessity. For those patients who are private pay or high deductible, we explore the financial assistance options. And for those who don't qualify for financial assistance, we'll work with the physician's office to reschedule the infusion if it's not urgent. For those whose infusions aren't medically necessary, we'll work with the ordering physician to clarify the diagnosis, see if we can get it covered. Many times the infusions are canceled or rescheduled for a later date when the patient will have the funds. Although it's amazing that offering significant discounts, the patient comes up with the money. So that discounting program that we have has been reasonably successful, and we look to continue that. We also are about to embark on using a piece of software which will give charge estimates to patients to give them a better sense of what their liability will be after the insurance company pays. And so we're kind of hoping that helps us in that process as well, Charles.
Okay. Hey, one last question. As you mentioned, most of the hospitals in your state are considering whether to become part of a larger system in one fashion or another. From your perspective, what are the pertinent questions that a CEO or board should consider in determining if it's time to look for a strategic partnership and in finding that right cultural fit that's going to carry out your hospital's mission?
Well, I think it's an excellent question. I could probably spend an hour talking about it because we've actually been going through this ourselves. I think it's a question about thinking sort of back to the mission and the vision of the organization, and I think you have to ask yourself whether or not the structure that you have today, what you're able to deliver today, is going to meet the needs of that mission and vision going forward. I think that's key. You have to just be honest with yourself. Do we have the wherewithal to remain competitive in a viable, relevant organization over the long term? And of course, what sort of leads you to that is looking at the financial forecasts. We have done a lot of work here in terms of trying to forecast out 5-10 years. I realize it's hard to predict really beyond a year or two, but you got to go through that exercise, and I think that can tell you a lot. Obviously back to the sort of understanding the federal and the state and the local trends, understanding the competition, how much penetration do we have in the market? Do we think we still have opportunity to bring in more volume to the organization? What are the needs of the community? Looking at the demographics, this is a resort area here at my hospital right near Lake Winnipesaukee. For those of you that may be familiar, we've got a lot of retirees that have settled in the area, and the average age of the population here in this area is 52 years old, compared to in southern parts of the state where it's in the high 30s. So we're rapidly aging area here, and that's going to carry with it some considerations as well. As I mentioned earlier, we're sort of up against the wall a little bit with minimum staffing situations in order to keep services open and available 24/7. I think that all gets back to the sort of vision and the mission. Who do we want to be, and how do we get there, and can we continue to do it on our own? With respect to culture, it's key. You've heard the term, I'm sure, culture eats strategy. It's true. As we've looked for potential partners, it's been a very, very interesting experience. We have some collaborative relationships and so on that have allowed us to get to know people. One of the things that's most interesting to us in a potential partner situation is understanding the desire to keep care local as much as possible, assuming that it can be done at high quality and at the appropriate cost, because we believe that there's tremendous value in keeping care local. So we look to another organization to see whether or not they embrace that. We look to other organizations' culture to see how much they're willing to sort of collaborate in teamwork on transfers and referrals. How receptive are they? How affable are they in terms of their response? What's the decision-making style? What are their cost and quality structures? Value. What drives them? What's their focus? Are they focused on the finances only, or are they focused on value, cost, and quality? Can you trust, and can you develop that trusting relationship? One of the challenges for us here, Charles, is that we have tended historically to have a very dispersed referral pattern, and so we don't have a particularly high concentration of business that goes to one of the, we have a number of surrounding facilities, yet we send business to every one of them. So we don't concentrate our business, with the exception of maybe cardiology, which we send to one particular organization that focuses on that. We have a very dispersed pattern, so consequently we really haven't developed any type of a long-term sort of trusting or working relationship where we're sharing a lot of commerce. And so when you start to look at, an affiliation, that comes up, as a problem. Is a lot of the successful affiliations and mergers, whatever you want to call them, that I've seen, they stem from organizations that have been working together for a long time. Maybe they've been sharing medical staff and so on. Well, that's not the case with us. So trying to sort of overcome that, we really don't know you kind of barrier, and building up that trust, is a tricky one. So.
Great response. Greg, I know that we're getting close to being out of time. We've had some questions from the participants. Do we have time for any other questions, or do we have to call time here?
Sure. We will take just a couple moments to open up the floor to any questions or answers that the audience might have. If you have a question for a specific presenter, please put your question in the text box. The first question coming to mind is for Vicki. Could you tell us a little bit about the revenue path and how the role of educating community and preventative health has been used to increase or after the revenue path?
Sure, and I would put a caveat to that to say that this is an emerging place. It's pretty easy to look at chronic diseases as an example, so I'm going to pick on them a little bit and say, you know, from many hospital and healthcare organizations, we do a really great job of taking care of a diabetic patient when they hit our doors. However, when they're out in the community, maybe we don't know that they're taking their meds, and we don't know that their diets aren't being followed and things that actually support them. So one of the things that I do think is starting to emerge, especially around chronic condition, is the idea that your outcomes generate or provide you an opportunity to sit down with payers in a different way. To either, for some it's employers, for some it's insurance companies, but to actually start to have those conversations around education for the community. And some are starting to think that we need to put care managers, very similar to the case manager role in the acute care side, and put a care manager around the role of helping to manage chronic conditions out there, and that includes education, and that includes some other kind of components. If your quality and your outcomes are starting to look like you're positioning yourself to be able to care for a population, that can position you a source of strength, and actually they may give you some incentives around that, or a variety of other kinds of options. So it's just starting to emerge.
One other question, this is for Dave. Is there any way that you would be able to give the attendees a copy of the monthly meeting model matrix? This, along with organizational transparency, these are very important. With the typical decades of experience with most hospital management teams, accountability is fuel for transformational change without expensive consultants.
Yeah, absolutely. Would be happy to provide that to you. And I guess, Greg, you can help me out with how we might deliver it to them. But, you know, what we try to do, we believe that anything that we do is about, we want to share, and we want people to improve. And so just like with our support service survey that we're doing, it's been implemented in, I think, 60 or 70 hospitals across the country already. So happy to provide that information to anyone that would like it.
Perfect. Thanks, Dave. And this question is for Mike. Regarding access to capital and cost containment, is real estate monetization and real estate optimization considered?
I haven't gone there here yet. Can you repeat that question again, please? Thank you.
Sure. Regarding access to capital and cost containment, is real estate monetization and real estate optimization considered?
We haven't. We've talked about it briefly here at Huggins, but we haven't gone any further with that.
Okay. And this is an open question to the panel. How do you deal with waste regarding IP stay and the ordering of unnecessary exams, especially those by independent physicians?
I may jump in this. This is Dave. This is Dave Callecod. What we have done is through our our service line management agreements, we have purposely went and picked the top performers of the private physicians in our community, many of which are part of the larger groups in the community, and then contracted with them to be responsible for the service line. What they then do is they establish protocols for the care of those patients, which then are adopted throughout that entire department. And so you have a coordinated group that's focused on the service line, focused on keeping and best practice and getting costs out of the system, and then that basically becomes the protocols that all of the physicians have to follow if they're on those units.
I
I would
And this
also,
is a
this is
French.
Charles. Yeah, I would also add to that. We've also taken that once we've developed best practices. We've also gone through the independent physicians and sat down with them and shown them where they're practicing outside the norm and asked for their cooperation there. It's something I think we have to monitor more and more closely and give the physicians the data to back up how they're performing. And I think most physicians, and with a few exceptions, once they see that they're not practicing within the norm, will begin to cooperate and work more closely with you.
And one final question for today's webinar. I have heard leaders say manage to margin. How feasible is that in real life?
I'm sorry, was that managed to Medicare?
Into Medicaid, maybe.
I just said manage to margin.
I think
Yeah,
I saw
so-
I think I saw managed to Medicaid margin out there earlier.
Yeah, so managing to Medicare is feasible, and having been in the for-profit world, there are a lot of folks that are able to make money off Medicare, and so that is possible. Managing to Medicaid, however, is absolutely not possible.
Yeah, especially not here in New Hampshire, where we get about 56% of cost.
That's exactly right.
Mm-hmm.
So, I just wanted to say one thing back to that monetization question of the real estate. We had a discussion about 6 months ago about the possibility of a sale leaseback of the main hospital facility here. It's just, we haven't gone any further with it. It is a bit of an albatross. We added a new facility here in 2010, probably more than we really needed, and we're carrying, $25 million in bond, two issues of bonds on it. I was just discussing it actually with my CFO yesterday to see whether or not that's something we might want to circle back to see if there might be investors or others that would be interested in working with us on that, because it is a sizable cost, not only in terms of the debt service, but the depreciation expense from an operating margin standpoint is just tremendous, for this small organization. So it really makes it almost impossible for us to achieve a positive operating margin when you're looking at that kind of depreciation expense. And I think, one of the reasons why I suspect this hospital and other critical access hospitals have gone after some of these new facility initiatives is that they could get, some of those costs offset through the cost report. But the reality is, when your depreciation expense is 10% of your total operating expense and it's driving huge operating loss, we can't refinance the debt and so on. So I think going back to that monetization thing and maybe looking at the potential for a sale leaseback might make sense. I just wonder who would do it.
As we conclude today's webinar, it is an honor and a privilege to have such a wonderful panel of speakers to speak to our attendees. The Central Illinois ACHE chapter is grateful and honored for that. After the webinar, you will be directed to a short survey in which the Central Illinois chapter hopes you will take the time to fill out. And that concludes today's webinar.